both metabolic function and mechanical function. So metabolic function and mechanical function are related to the mass and the strength the muscle is generating, because these are simple non-invasive measures which you could clearly do in a clinical setup, and you could translate that into a prognostic marker of an individual during post-surgery, or if an elderly or any other clinical condition, if you want to look at, you have to derive the muscle quality in order to assess both mass and function. Of course, it does indicate about how much is the contractile myofibrillar protein content and also the mitochondrial functionality. On the right panel, you can see here that it's important for us to maintain both mass and function. The rate of decline of function is much steeper than the mass. An individual could appear to have retained the muscle mass, but the strength tends to decrease, and it's purely dependent on how much of the balance is there between the muscle protein synthesis and breakdown. So we have looked at some of the studies and compared our study. Here we took healthy individuals and compared both males and females across the various other studies, and we found that our population was significantly lower compared to other population. So moving on to skeletal muscle metabolic function. So in terms of diabetes, it's important for us to understand the skeletal muscle metabolic function, because muscle interacts with other organs, or there is something called as the inter-organ crosstalk. So you have a crosstalk between pancreas, you have between adipose tissue, liver, and skeletal muscle interacts with all the organs in order to maintain the glucose uptake, or in order to the fat metabolism, which we will be talking about in a bit now. Now, the skeletal muscle, the substrate is important because you have to undergo the substrate uptake, which I was talking about, particularly the fatty acid as well as the glucose. And insulin plays a very important role in order for the glucose uptake. At the same time, here in picture, you can see that both fatty acid and glucose are important because you're providing the substrate for the mitochondrial functionality. Ultimately, please remember that in order for a muscle to generate the kind of energy or the kind of strength or the force it can generate, it depends on how well it can take this substrate inside, at the same time generate energy in order for those contractile elements to slide over each other and generate that force. So the metabolic function is related to mechanical function if you are able to perform substrate intakes and also the mitochondrial functionality. So if there is an insulin resistance, there is alteration in lot of uptakes of both glucose and fatty acids. So we have been working since couple of years now on various aspects of metabolic and mechanical function. So we have gone ahead and measured their insulin resistance through HOMA. We have looked at the muscle function in terms of using isokinetic dynamometry. So here is one of the published studies in which we have shown that there was a association between the muscle quality as well as the insulin resistance, which was a negative association. And surprisingly, we found that there was a positive association between the muscle mass and the insulin resistance. So we expected that as one developed diabetes, there will be a decline in both mass as well as the strength, because we expected that the mechanical and metabolic functions will be altered. But what we found was that the muscle strength was reduced, which is the ratio of the mass and strength, and the muscle mass was somehow retained or maintained in these individuals. Now, from the same study, here you can see that when we looked at the total body fat, we were surprised that the controls, pre-diabetes and diabetes, were all having the same amount of body fat. As I mentioned to you, the pre-diabetes versus the diabetes in relation to controls were all having the similar appendicular muscle mass. But what was interesting was that their strength was much lower. In fact, the pre-diabetes and diabetes were having similar strength. In other words, their muscle quality deteriorated as soon as they attained a pre-diabetes status. So, though the diabetes, type 2 diabetes individual had still lower muscle quality, but the muscle quality between pre-diabetes and diabetes were similar. We went on looking at were they sarcopenic, because sarcopenia is status which is universally looked into whether the muscle mass is reduced. So it is derived by using a simple index of skeletal muscle mass index, where you divide the mass by the height in order to derive skeletal. But please note here the strength is not used, only the mass is used. To our surprise, none of the diabetics, neither pre-diabetics, were sarcopenic, which was a clear surprise. On one hand, we showed that their muscle quality was poor. On the other hand, when you would use indices which are universally used in terms of muscle mass, we found that they were not sarcopenic. And this was a surprising point for us, where we were surprised to see that why these individuals are not sarcopenic in spite of having the type 2 diabetes. So we went back and started looking what are the definitions for diabetic myopathy, and we found that by definition, diabetic myopathy is characterized by reduced mass, weakness, and also physical functional capacity. Though none of the individuals in our cohort were physically functional capacity were reduced, the only thing which we could uncover were the muscle weakness, or the strength of the muscle was reduced. But by definition, the muscle mass should have been reduced, but we didn't find that reduction in the muscle mass. So this raised a very strong kind of debate or question among us, our peers, wherein why, if muscle mass is maintained among Indians and with pre-diabetes and diabetes, what is the mechanism? Why are they able to maintain? Is it a unique feature among Indians? If so, are we or should we look at something else beyond just looking at the muscle mass? So we suspected that maybe Indians are accumulating more fat within the muscle, and that is allowing them to give a picture of maintaining the muscle mass, because DEXA doesn't measure the fat within the muscle. So we thought, is it the intramyocellular fat which is accumulating in Indians, which is giving them the bulk, which might give us a false impression that they are not losing the muscle bulk. So we have done a couple of muscle biopsies now, and this is the picture of various needle. We use a needle called Bergstrom needle. We do biopsy in the thigh muscle, vastus lateralis, and here are some of the small bits of muscle which has come out, and we take them through various processes. And this is a process of cryosectioning, and some of the images being stained after immunohistochemistry. And you can see that in the next slide, that when we compare the fat within the muscle of control versus pre-diabetes, the values of the orange droplets, what you're seeing here is the fat which is accumulated within the muscle. And it's a very clear picture showing that Indians seem to accumulate more fat within the muscle. Now you might ask me why. That's the next question. We are trying to understand why is there more accumulation of fat within the muscle. But it was very clear from this paper, which was published, that Indians seem to have accumulating fat even at a pre-diabetes status. And then when we looked at the values after image analysis, we could see that the intramyocellular fat was even 2 to 3 times higher compared to even a control normal American or European population. So even our control population were higher, but the pre-diabetes population was much higher than the control population of the other ethnicities or other populations. So it was very clear from this study that we are accumulating fat within the muscle. So we are exploring what are the mechanism at this stage by looking at various proteins which are regulating called perilipins, and some of the metabolomic analysis which we are doing in the blood, but tissue metabolomic analysis would help us understand, are there any lipid intermediates which are getting accumulated, which are not able to be utilized for the energy metabolism. Interestingly, this trial is now completed and we will have to now publish this paper, but I just wanted to share a picture of the before and after exercise program which we performed on pre-diabetes individuals. And you can see here very clearly the orange droplets which an individual accumulated at the start of the trial completely or came back to a normal. Or if you remember the previous slide, the control individual, the orange droplets were quite less. And interestingly, they also improved their glycemic status from this study. In this trial, we used combination of both aerobic and resistance exercise and also gave them some amount of protein supplementation, but it was a randomized study, open label. But at this stage, I won't be able to tell you whether this person was taking with protein or just an exercise, but all of them received exercise, and this trial showed us that exercise does work in order to reduce your fat, particularly within the muscle. Just to touch upon the muscle fibers, what we have. So we do have two types of muscle fibers, type 1 and type 2. The oxidative fibers versus the glycolytic fibers are important because there is some concept called as fiber type shifting. Now, if there is a shift of towards the glycolytic fibers, then the person has the ability to move towards the or it develops the chances of developing pre-diabetes or type 2 diabetes. So interestingly, when we looked at the type of fibers within pre-diabetes versus healthy control, we found that they had more of glycolytic fibers compared to oxidative fibers. So it was very clear that when an individual has moved from being a control to a pre-diabetes status, not only they started accumulating fat within the muscle, they have started changing their fiber types to be more of glycolytic fibers. At the same time, we also noted in the previous slides that they had lesser strength in the muscle. So these were some of the findings which we have been able to uncover in case of pre-diabetes population, and some findings which are able to also study in the type 2 diabetes. So why is it important to look at fiber types? Because if you have more oxidative fiber, then the fatigability is much slower compared to glycolytic fibers, where the fatigability is much faster. We have to still look upon after the exercise program, were they able to shift from glycolytic to oxidative fibers is something which we have to still look at it. But in the cross-sectional data, when we looked at the pre-diabetes versus control, we found that the pre-diabetes seemed to have more of a glycolytic fibers compared to the oxidative fibers. So what are the different strategies which we could adopt in order to improve your muscle quality? So the first question you might ask is,
resistance to exercises and
what form of exercise can help improve the muscle quality? It could be either aerobic resistance and aerobic and resistance. So you could either ask a person to perform only aerobic, or you could ask a person to perform resistance, or a combination of the two. Generally, even though ADA guidelines gives us to perform all of them, in a clinical setup, generally we encourage individual to do a simple walking, particularly say half an hour of walking. But we'll understand during the course of next few slides how it is important, particularly in Indian context, to adopt even a weight training or combination of the both. This is a very interesting study where they looked at, in terms of the muscle quality and individual fitness. So we are not only translating the role of muscle quality, but also trying to understand whether an individual becomes much fitter after improving their muscle quality. So here is a study or a trial which was done on 190 type 2 diabetes individual, where they were given a combination of both aerobic and resistance exercise, and they looked at these individuals dividing them based on their muscle quality. So they were having low tertile of muscle quality versus high tertile of muscle quality. Interestingly, what you can see here is that an individual who had higher muscle quality at the beginning did show better improvement, but this is a change. What you're looking at is the change in the value from before and after. But it was also interesting to see that some of the values improved even in the lower tertile. So, in summary, what I'm trying to say is that by giving an adequate amount of exercise, which is a combination of both aerobic and resistance exercise, you can not only improve their insulin resistance status or they can become better glycemic status, they can also improve their overall fitness of that individual. So, what is required? Or generally, we don't think of exercise as a prescription. We generally recommend them, you do some form of exercise, but we never specify them what kind of exercise they have to do and how or how long they have to perform these exercises, though it is told that please maintain certain steps or half an hour of simple walking. But is it important for us to pace their walking? If they are pacing, what are the different factors we have to consider are some things we'll touch upon. So one of the most important thing is pre-screening or the pre-exercise screening. So as a nutritionist, it's very important for you to ask an individual what are the difficulties an individual has. Do they have any defects or they have any other diseases like cardiovascular or respiratory disorders, so that you are well aware that they will not be able to maintain the prescribed amount of exercise. At the same time, you should also ask them about their hypoglycemic events or how many times have they developed hypoglycemia, because in order to prevent hypoglycemia during exercise, it's important to closely monitor what kind of drugs they are taking and prescribe exercise regime accordingly. And of course, the most important, the world is moving towards the personalized exercise designing programs. Now, this depends on how much of vigorous exercise you want to prescribe them. I'll touch upon few things in the coming slides. So here is Canadian Diabetic Association has put up a beautiful program of how you could actually prescribe these exercises. So here is a pamphlet which you could design for your patients or your type 2 diabetes patients who visit you. So here are some of the prescription and regimes which actually they describe, which goes on to talk about how do they start and what are the different kind of exercises you can perform. There is also a sample step count prescription. And of course, this is important because we never consider asking an individual were they able to attain the targeted steps. And nowadays, most of the mobile phones as well as your watches actually are able to provide these step counts. So this is something I thought will be very useful for individuals who are planning to look at these aspects. Of course, the physical activity, a position statement which came in from the American Diabetes Association, which talked about the type of exercise, the intensity of exercise, and duration of the exercise. So it's important for us, at least for an Indian diabetic, to include some amount of weight training. It need not have to be in the gyms. It can be even free weights, resistance band, or even you could prescribe, or nowadays a lot of videos are also available to give them own body weight or what is called as the calisthenic exercises. And it's important for us to involve some amount of resistance training along with the aerobic training in order for them to improve their muscle quality or the bulk. Of course, these guidelines are available, how many repetition, how many sets an individual has to do. And of course, the aerobic training, either you can talk about in terms of number of steps an individual attains or the duration an individual could work upon. A brief account on the protein aspects of the exercise and how does it affect, because literature has indicated that an adequate amount of nutritional intake along with the exercise is far important. And here is a slide which has reviewed all the literature which are available both in untrained and trained individuals. And here you can see that the favoring towards the protein supplementation both in trained and untrained individual in order to increase as an outcome their mass and strength. So this systematic review focused on the protein intake, whether it can improve mass and bulk and strength in order to improve their muscle quality. And it was very clear that the protein intake does help in order to improve the muscle quality. What about the dose? And here is the same studies were taken. And here you can see that individual circles are those studies which I have shown in the previous slide. You can see that when they looked at the total protein intake versus the delta change in the fat-free mass around, and they did a segmental linear regression analysis were performed using the on the DEXA data for the FFM, and it was shown that they attained a breakpoint at 1.6, and it indicated that even if you increase the protein intake beyond 1.6, there was no increase in the fat-free mass. So this review was important in this aspect. What type of protein is important? So here is a slide which talks about both concentrate and isolate of various proteins. But what is important is more than the source of protein, it is the kind of amino acid composition the protein has. And here is the picture of the different kind of amino acid composition, particularly the leucine amino acid reference ratio. And it's important for us to pick up a protein which has a greater ratio of branch chain amino acids, and whey protein seems to have that. So does the type of protein matter? The answer is here is a study which looked at the intracellular leucine levels versus the muscle protein synthesis. And it was shown that a protein which has more leucine level had more muscle protein synthesis response, indicating that following exercise, if you do give a good quality protein, the amount of muscle protein synthesis improves, indicating that the selection of the right kind of protein is also important. Finally, I just wanted to touch upon, because ketogenic diet is something now has sort of gained momentum. So does ketogenic diet improve muscle quality? Here is again a systematic review which looked at various studies, improve in the lower body mass or the leg muscle mass they have looked at. And the studies have been mixed. Majority of the studies indicated that there will be either no change or it will not cause any harm, but it will neither improve your muscle quality. So I just want to end this presentation. Some of the things what we do actually indirectly reflect upon the kind of support the volunteers give us. And here is an individual who was not able to even climb a couple of stairs. He was a young individual who was diagnosed with pre-diabetes. He joined our program, and we started following up, gave him continuous prescription of exercises. And following that, he was able to complete half marathon. And he wrote back to us, sending this picture, telling that it's about the role we play in an individual. It's not about just prescription, it's about follow-up. It's about how well we can give this care and making them understand. It's important for us to understand why is it important that these recommendations are given to these individuals so that they can follow and improve their lifestyle. So finally, to summarize, skeletal muscle has a role in type 2 diabetes. It is undisputed that it does play an important role in type 2 diabetes. And we were the first group, at least in Indian population, to show that we tend to accumulate more fat within the muscle. And by incorporating some amount of weight training exercise, we can actually start mobilizing this fat. Is something the evidence is emerging out of our group. And including some amount of protein intake could help in order to build muscle strength as well as the muscle quality. I have a whole lot of people to thank. Majority of the funding on the muscle biopsy and some of the pre-diabetic studies were funded by India Alliance DBT Welcome. And there are studies which are ongoing. There are studies which have been previously done. And I have whole lot of funding agencies to thank. And of course, my collaborators and my mentors, starting from Professor Kurpad, Professor Harij, and whole lot of other people and my team. And of course, last but not the least, the volunteers who actually came to these studies in order and gave their muscle biopsies in order for us to perform some of these studies, which we are able to do it. Finally, I would say thank you once again to the organizers for giving me this opportunity. Thank you.
Thank you, Dr. Sucharita. Indeed, a very insightful talk. So next time we see a diabetic patient, we would not just think in terms of the diet, the portion sizes, and the routine things that we look into. We would probably look into the type of exercise they are doing, the frequency at which they are doing, and most importantly, one thing that I think all of us should remember is Indians have a tendency to deposit fat in the muscle too, and that is what you have just wonderfully explained. I have a question for you, Dr. Sucharita. Does the intervention with respect to exercise alter the HbA1c levels in pre-diabetics and diabetics? Did you notice anything on these terms during your study and during your experiment with the pre-diabetics?
Dr.
Yeah.
Sucharita, you can stop sharing the screen.
Yeah, thanks, Sunita. We did look at their glycemic status, and there was definitely improvement, but not all of them showed the similar responses. Now, ours is a RCT, so as I told you, we will be able to put a light on that in a couple of days. But the literature has shown very clearly, and I didn't put up the systematic review which have been looked into whether aerobic exercise helps, does only resistance exercise help, or combination of both resistance and aerobic helps the improvement in HbA1c. Now, the literature has indicated that any form of exercise is good enough. For example, if you're solely looking at the HbA1c improvement, even an aerobic exercise could help it. But if you want to look in a long term impact, that is, an individual is able to sustain his fitness, sustain his glycemic status, he has to build that core infrastructure or the other organs which support this. In order to do that, we have to look at how we could improve the quality of the muscle. So, a simple answer is any form of exercises improves HbA1c. There was no difference between only resistance versus aerobic. In fact, aerobic exercise improved more HbA1c, or a better percentage was achieved than resistance alone or resistance with aerobic. But as I explained to you, that it is beyond HbA1c. HbA1c is only a 3 month short-term effect. But we have to look at the long-term effect, how we could improve the glycemic control.
So we have a question here from one of our participants. Ramya is asking, need one suggestion on commercial products to increase the muscle mass for sports persons. So do you want to throw any light on any particular kind of supplement for improving muscle mass in sports persons?
So I could talk about the composition of the protein, irrespective of what kind of product they are taking. But the composition of a good amount of branched chain amino acids that the protein has, and increasingly, as I told you, whey protein does seem to have a better quality of protein in terms of the amino acid composition. So whey protein would be the choice in order for them to start using the protein, particularly whether it's an athlete or whether it's in non or inactive person. Whey protein would be the choice.
Thank you so much. I think you have answered this question in your talk, but I would just read it out in case you need to add anything to this. What if a person is exercising rigorously and is not taking sufficient amount of protein through diet or supplements? What about his muscle strength and metabolism? Would you like to add anything else apart from what you have mentioned in your talk, Dr. Sucharita?
So if you tease out, does only protein intake improve the muscle quality, or by adding exercise and protein, does they improve the muscle quality? We actually went back to the literature and looked at the effect of only protein on the muscle quality and effect of only exercise on the muscle quality. And based on our review and back calculation, we found that around the contribution of only protein was around 2 to 3%. But the effect of exercise was around 14 to 15%. But why is protein important? The protein is important because I told you that when you exercise, there is breakdown of your muscle proteins. Now, by supplementing protein immediately after an exercises, any form of exercise, the replenishment of this protein becomes the muscle protein, what we call as the contractile protein, becomes faster. Or in other words, literature has shown that once the muscle breakdown happens, if the circulating pool of the amino acids are available, the uptake is faster. So it is not about the percentage of improvement by only taking protein or exercise. Exercise does have a better or a good effect. But by giving protein along with exercise, you're replenishing the nutrients which is required for the uptake and muscle protein synthesis. So it's like you're putting some water for the plant to grow faster. So it's something like that. So maybe that answers the question.
We have a question from Shalini. Any effect of intermittent fasting found on muscle quality?
That's a important. That's a good question. In fact, we had proposed. Uh, uh, we had written up a proposal looking at the intermittent fasting. Does it have an impact on the muscle quality? Now, literature has shown that intermittent fasting is known to cause some amount of weight loss. If the intermittent fasting alone is done, then you might not have any improvement in the muscle quality. However, if you include intermittent fasting along with some amount of exercise, then you will start building with intermittent fasting, you might start losing fat. By doing exercise, you might start gaining muscle. So put both together, don't do only one. Do intermittent fasting with exercise.
So you're suggesting that there is a dual advantage, one of fat loss and one of improving muscle by supplementing good protein and exercise along with intermittent fasting.
Yeah. So protein supplementation, you have to consider based on the daily requirement. It's not about just taking additional protein you're going to meet up. In fact, you have to back calculate and see whether the intake of protein is meeting the requirement. If an individual is based on the Indian diets, you might not be able to meet the requirement. But it's important as nutritionists to first check whether they are taking adequate amount of protein. If they are not taking, it is important for us to recommend depending on the requirements. And of course, exercise is the key. More than protein intakes, of course, protein adds to the value, but do exercise and the right form of exercise. And we have now thinking that resistance exercise recommendation should be included in all our prescriptions in order for an individual. And the other thing I just want to add in is that it's not about heavy weight training. Whenever we add resistance exercise, people start thinking I have to go to the gym, I have to lift so many weights. It's not about that. Some amount of lift or some amount of body weight training is sufficient enough to improve our muscle quality.
Was there any particular regimen that you used during your training session or during your research? The regimen for exercise.
Yes. So if you go and start looking out for what kind of resistance exercise programs are available, you could have something called as the progressive resistance program. And when you build up this resistance exercise, you use a index called as the resistance maximum or the RM. The resistance maximum, when we did our preliminary trials, none of our participants could go beyond 40%. So what is resistance maximum? It's the maximum amount of a weight a single group of muscle can be used to lift. So if I'm using my forearm muscle, I can use certain weights, maximum weights I can lift. And we found that majority of our population could work around 40 to 50% or lesser than that of the resistance maximum. So ideally you should reach up to 60% in order to increase your muscle bulk or quality. And people who do put on muscle mass use 70% of resistance maximum. Coming to what did we follow? So we first measured the resistance maximum. How do we make? You have to just ask people to lift the weight and check what's the resistance maximum. We trained them for 15 days. Please remember, never ask a person to start exercising weight training immediately. So we gave them a 15 days trials where people could understand what is stretching, what kind of, and nowadays a lot of videos are available. So it need not have to be on one to, but we used a trained individual, a trained physiotherapist in order to give them how to do it. And then we started something called as the progressive training, which looks into every month how much percentage we could increase in resistance maximum. So in other words, for us, progressive resistance training has worked out, but you could simply do a simple protocol of resistance training for a couple of months, and we used a 3-month protocol in order to assess their glycemic state.
We have some questions coming in from our YouTube streaming as well. One of the questions is by Dr. Lalita Reddy. Walking is considered as resistance exercise, functional exercise where your body is used as weight. Can you please comment on this?
As far as I understand, simple walking is not considered as a weight training. You need to put some amount of load into the muscle. Now, you can simply argue that you are putting a load by walking, but that load is not sufficient enough in order for you to call it as a resistance exercise. So, what I was talking about loading and unloading of the muscle, the simple walking is classified as an aerobic exercise. The aerobic exercise does improve the muscle quality by improving the mitochondria quantity as well as the functionality of the mitochondria. The resistance exercise or the weight training increases the bulk of the muscle as also the force what it generates. So both are important. Simple walking is not called as resistance, but it's called as an aerobic exercise. The resistance exercise or the loading of the muscle is also important. So as I told you, both are important.
Sunita, are you there? Do we have more questions?
I'm there. I just suddenly lost the audio. Are you able to hear me?
Okay.
Yes, I'm able to hear
we
you.
can.
Okay. Yeah. So I hope that answered the question, Lalita ma'am. I'll move on to the next question. What is your take on musculoskeletal changes post-delivery and how to regain the strength, particularly abdominal muscle? Is there anything you would want to comment on this, or if this is in the purview of the session?
See, abdominal, so we broadly divide the muscle groups into upper limb, lower limb, and the abdominal muscle. So these are the 3 to 4 compartments when you prescribe exercise you work upon. And post parturition or delivery, the abdominal muscle strengths are something people look out to improve. I think there are the same exercises. So there are certain prescription for lower limb, upper limb as abdominal and thoracic muscle exercises. So but the same protocol applies. That is, first you look at the resistance maximum, and like for example, there are certain exercises which can directly tell you the core strength of the muscles, particularly in the abdomen. But thorax and abdomen comes together, and we usually look at upper limb muscles, lower limb muscles, and the abdominal and thoracic group of muscles. The whole chest and abdomen group of muscles cannot be separated. Of said and done, you could involve the same principle. That is, you could plan an exercise which is dependent on the amount of maximum weight a muscle or can be lifted, or adopt if you are doing your own body training, adopt an exercise protocol which is repeated in order to improve the core strength. So for diabetes, we focus more on lower limb and upper limb, but in this context, the same concepts can be used to strengthen the abdominal muscle as well.
Okay. Yeah. Can we take 3 more questions, Sandhya? Do
Yes,
we have
yes,
the
we
time?
can. Yes, we can. Dr. Sucharita, you have time, no?
Yeah, please go ahead, no problem.
Sure. Sure, Sunita, please go ahead.
So in your okay, thank you. In your pre-diabetic study, how much protein did your participants consume on the basis of kg body weight, per kg body weight? Is there any regimen that you followed during the study?
Yeah, so you could either go in two ways of dealing with this. One is you could look at per kg body weight, and or you could actually fix the protein intake.
Just a minute, Dr. Sucharita.
Yeah.
I'll just mute everybody. You can unmute yourself now. Dr. Sucharita, you can unmute yourself.
Okay. Yeah, I have done that. Can you hear me now?
Yeah. Yes,
Yeah.
yes, we can hear you.
So in
Sorry
our
for the
study,
interruption.
yeah, no problem. So the question was how much protein did we decide on the study which we did. So as I told you, you can decide on the protein for an individual depending on the RDA, or you could fix a fixed dose of protein to the given group. Since we were doing on a population which was given BMI, or we had looked at only male population, and we had looked at BMI range which was restricted to certain level, we thought it's ideal for us to give a fixed amount of protein. So 20 grams of whey protein was given to these individuals. But as I told you, you could either per kg body weight you can calculate, or you can use fixed dose. Now, why did we select 20 grams? Because again, we did a massive literature search, and we found that you can either go in the order of 10 grams, 20 grams, and the effect on muscle quality did not change in one of the studies when they gave 40 grams. So we found that an optimum level of 20 grams was sufficient for us to look at a change in the muscle quality.
So any recommendations you have for geriatric patients, say about 70 years, specific recommendations for improving their muscle mass?
So this is the study which we are currently running, wherein we are looking at what kind of exercise. One of the challenges in a geriatric population is they will come with comorbidities, and the renal compromise might be there. And one of the issues is whether you can even give them protein or not is a big issue. So there are a lot of recommendations which are already put out in terms of protein intakes for elderly. Once you check out that the renals are quite good or the kidney functions are normal, and currently we are looking at healthy elderly population. So for that we are adopting the same recommendation of the whey protein. Along with exercise will not be the vigorous weight training which I talked about in the pre-diabetes, but we are looking at more of a subtle resistance band kind of weight training in the elderly population. So still this trial is on. We don't, and this is one of the studies which will be using gold standards like potassium counter and isokinetic dynamometry in order to come up with some sort of standard recommendation. So how much of protein and exercise could improve muscle quality is something we'll have to try out for Indian population. But otherwise, the standard recommendations are out there for the elderly population.
This one's very specific question. Will high protein diet increase oxidative muscle fiber?
So, high protein diet will increase oxidative muscle fiber. So, I think let's shift back and understand what do you mean by oxidative muscle fiber. So, the oxidative muscle fiber is it has more of mitochondria, or it has ability to generate more energy. Okay, that's the characteristic of the oxidative muscle fiber. When you have higher quantity of protein intake, the contractile proteins, that is overall proteins, increases. It need not have to be specifically the oxidative muscle fibers. Okay. Now, I have never come across any study which has specifically looked at supplementation over oxidative improvement, but exercise has been shown to shift the glycolytic to oxidative, vice versa also oxidative to glycolytic. So answering your question, protein indirectly working with exercise might improve oxidative fibers, but protein intake alone might not have any role in the oxidative fiber. Maybe that's a simpler way of telling.
Okay, thank you. So for a person who is handicapped and cannot walk, can we preserve muscle by doing only upper body exercises?
The answer is yes. In fact, literature has done something called as the one limb exercise, wherein these are classical experiments which are done to understand what are the changes as one limb as control and the other limb exercising limb. So you actually only exercise on the right side of the body and left side of the body is not exercised. Vice versa, people have done both upper limb exercises and not done lower limb exercises. Now, a simple answer to that is more the merrier. More muscle bulk or the more muscle you involve, the advantages may be more. But even if a person is handicapped, if they focus on the upper limb muscle, it's still good enough for them to improve the muscle quality.
So you were just explaining about the role of walking in improving muscle quality. There's another question related to walking. Your opinion about combination of walking 4 steps with running 4 steps.
So what we have done in fact, one of my PhD, who is a post MD doing a PhD, is looking at a question about the pacing of the exercise, pacing of the walking. So how do you tell a patient or how do you tell an individual? I'll come back to this question of 4 steps of walking and 4 steps of running, but it boils down to the pacing of the exercise. Now, the pacing of this exercise should be related to how much of heart rate you're able to achieve. So whether it is 40%, what we call it as the VO2 max. VO2 max is the maximum amount of oxygen a person can consume. 70% of the heart rate is related to a VO2 max. So in other words, you can't attain 100% of VO2 max is not equal to 100% of the heart rate. There is a deficit, or the maximum you can attain is 70% of your heart rate. And we usually calculate by subtracting 220 minus age in order to derive the maximum heart rate of an individual. And you design 40%, 50%, 60%, or 70% of your heart rate to reach VO2 max. So what we have been doing is that if you pace the steps, like for example, an individual the length of the steps and also the rate of the steps. If you start checking this out, and what we have done now is match this with some kind of music, what they are interested in. So every beat, if they hear, they have to put a step forward. So answering this question, if you're running 4 steps, you will be increasing your heart rate faster. Maybe you will be at 60% or 50% of your heart rate. If you're walking 4 steps, then you're working at, say, 30 or 40% of your heart rate. Higher the percentage of heart rate you attain, that is, when you're running, it is better. But not all of us can run. So, in simple words, by pacing your steps and doing required amount of time is still for a middle-aged and elderly is important. If you're young, the person who is asked is quite young, and if you want to, then it is better to run or follow any of this regime what they are asking could be done. So the mechanism what I explained is simply dependent on how much of heart rate you're able to achieve.
So if the person is able to jog or run and increase the heart rate, then that would be it. That would be the best. Otherwise, pace the exercise to the capacity that is possible.
Absolutely.
One question I have is this equation of 220 minus age for the heart rate. Is it important to apply this for all age groups, or is this generally applied after a particular age?
So you usually try to use this if you're in the middle age or younger to middle age, it might be used because let's take an example of 220 minus 20, your maximum heart rate you could reach is 200. But as you grow older, your ability to reach that level of heart rate is not possible. So generally, this kind of formulas, it's a very simple formula, but it's not that you can't apply this for elderly population, but the risks which are involved, if you start prescribing the percentage maximum heart rate to these individuals, the risks involved in terms of cardiovascular ability, respiratory ability to maintain, to achieve this heart rate is not possible. So in simple words, I would recommend this can be used for young and middle-aged with who are fit. I mean, of course, not that 220 minus age gives you maximum heart rate, and you should not suddenly jump into attaining that 70% of maximum heart rate. Please make sure your heart and lungs are fit enough to attain this maximum. That's what we recommend.
Thank you so much. It was a really insightful and a wonderful session, Dr. Sucharita, and with the questions answered, I think we are even more informed, better informed now. On behalf of IDA Bangalore chapter, I thank you sincerely for taking out your time and giving us this wonderful session. Thank you so much. And I also like to thank the participants who have been so interactive with all the questions, and without the participants, the session wouldn't be a great success. Thank you very much. I would also like to thank IDA Bangalore chapter, Dr. Sandhya Singh, convener, for having given me the opportunity to moderate this program, and all the LEC members of IDA Bangalore chapter for having coordinated and making this session a real good success. Thank you very much. Thanks to all of you, and Dr. Sucharita, thanks once again. Over to you, Sandhya.
Thank you for that insightful talk, Dr. Sucharita. It was really, really very insightful. And we should definitely plan another session where we will have some practical, practically we are going to show how to, measure the muscle mass and things, which we can implement it in our OPDs for, measuring the muscle mass, because there are simple techniques like, using the hand dynamometer. Even that, if we can do it properly and use that, information in our publications, it will be very good. Based on your availability, probably, we will get in touch with you again. Thank
Sure.
you so much for your time. Thank you so much for taking out time from your busy schedule for Indian Dietetic Association.
Thank you all. I think it was a pleasure for me to share, and it's always pleasure to interact with you all. And regarding the methods, I think let's plan something for all those who are interested to understand these techniques. It can be even an online session where, with the given scenario where one-to-one basis might not be possible. If they do have any kind of dynamometers in their setup, I think we could have an online session where we could show them how do you calibrate, how to use it, what kind of positions to attain, and so forth. What we did last time, we could try to achieve that in a small 1 or 2 hour workshop as well. I think I'm very open to that. And once again, thank you both, Sunita and Sandhya, for this wonderful opportunity. And hope to meet you soon. Thank you.
Sure. Thank you so much.
Thank you. Bye.
Bye-bye. Dr. Sucharita, if you're there, can you just switch on your video? We'll take a picture, please.
Take a picture, please. Yes.
Sure, I'm there.
The participants who are all there, can we just, request you to switch on your videos? Geeta, Namrata, Sushma.
It's great to see all the participants here.
Yeah, I
It's been a
repeat,
while
can you
since we
please?
had an offline session.
Yes. We missed those sessions. Can I request everybody to switch on your videos, please? Yeah. Thank you, Dr. Sucharita.
Thank
Thank you, everybody.
Bye.
Bye-bye.